Respected Chairman, Panelist, and my learned audience. Good afternoon, everyone. My topic is the angiogram that rarely I have seen. So let's see my patient. He is Mr. AMK, 58 years old. He is hypertensive. He presented in the early morning with a typical angina for 2 hours. Presenting blood pressure is 110/70 and pulse is 95 beats per minute. In EKG, there are ST changes in the multiple leads. This is the ECG, indicating that possibly patient has got multifacial disease or late main disease. He has mild apical hypokinesia in the echo, with ejection fraction is 50%, and troponin is positive. So, this is a case of non-STMI, high risk. He was optimized with the medicine initially in the emergency department. After initial treatment, his ECG improved. But he has ongoing angina with gradually low blood pressure. Considering the unstable hemodynamics, very high risk non-STMI, he was planned for early angiography. Patient was brought to the cath lab within 2 hours of the presentation. So this is the left-sided angiography. Unfortunately, occluded left main, but RCA is normal. Naturally, scenario is worsening gradually. Patient goes to the cardiogenic shock. He was given optimal multiple inotropes. And patient is a father of a doctor of the same hospital. In this scenario, what to do? Rescue PCI or CABG? Clinical scenario is like this. Non-STMI with unstable hemodynamics, left main total occlusion, normal RCA. He is a father of a doctor of the same hospital, and lot of attendants are outside waiting for the good result. There is no mechanical circulatory support in the hospital at that time. Synthesis score is 40. I considered 40 because to calculate the synthesis score, we have to give the information regarding the LAD and RCA. So if I consider the occluded left main, the synthesis score goes to 40. There is strong surgical backup. So far, there is no clear-cut guideline. So, cardiologists thought that patient will be benefited by surgical intervention. So, referred the patient to surgeon. And for intervening time, patient was sent to the critical care center for immediate stabilization. In the critical care center, patient developed VT, cardiac arrest, patient was resuscitated, kept on inotropes, and cardiac system declined to operate the patient. At that time, patient is in cardiogenic shock, ejection fraction further reduced to 35%. So only option is either PCI or medical treatment. Heart teams, including the cardiac surgeon, anesthesiologist, all available seniors sit together, discussed with the NOK regarding the possible worst outcome, and considered the risk and benefit of the procedure, and then plan for the rescue PCI. Basically, this is the scenario for a cardiologist who is operator. Like that, he is in the firing squad and facing the immediate disaster. So, once patient is the cardiogenic shock, rapidly patient was wired, and after balloon dilation, patient again developed cardiac arrest in the cath lab table. He was reverted to the sinus rhythm, and after resuscitation, This is the coronary, left side coronary. Distal left main is critical, and there is diffuse disease in the LAD and LCX. What we can see here, critical left main with diffuse disease in LAD LCX, and what we can do, we decided to put the stent to the distal left main. But patient is continuous on VT, CPR is going on, and simultaneously if maximum effort was taken to to put a stent to the left main. At one stage, stent was implanted in the distal left main, and patient again developed VT, resuscitated again, resuscitation going on, and this is the final result, fairly final result after stenting. But still patient is on CPR. After CPR for about 30 minutes, unfortunately patient died. What lesson learned in this patient? There are some facts here. We all know that incidence of acute MI with cardiogenic shock is almost 7 to 10%. In hospital mortality is almost 80%. Around 50 or 60% of patients had triple vessel disease, and with 20% patient involving the left main. There are a lot of guidelines to support the acute MI, non-ST-MI and cardiogenic shock. But what says about this type of patient? Shock patient, there are both options, revascularization and medical treatment, but revascularization favors in patients who present with the shock in the early stage. If you see the guideline, emergency coronary angiography is recommended in patient with ACS with cardiogenic shock. We did this part correctly. If you see here, in patient who require revascularization for significant left main disease with high risk, high complexity coronary disease, it is recommended to choose CABG over PCI to improve survival. But here, significant left main disease, left main is not occluded. So guideline is not clear here. Regarding the use of mechanical circulatory support in the cath lab during the high risk patient, there is a role of IBP and Impella. And both this GUSTO and shock trial, they describe in favor of mechanical circulatory support, although 6-month outcome was almost similar in both cases, both groups. And there is a recommendation that for non-STSCS related mechanical complications, the use of IBP should be considered. It is class 2A indication. We did not have this facility at the time. If you compare the ESC and JSC guideline, SSC guideline, both considered emergency angiography and emergency revascularization for shock patient. But there is no clear-cut indication regarding the occluded left main. So this is one of the recommendations. It is recommended to base the revascularization strategy in multivessel disease, PCI or CABG, on patient clinical status, comorbidities as well as the disease severity. One thing they have mentioned, the decision on immediate PCI of the culprit lesion stenosis does not require any heart team consultation. So whatever you want to do it immediately. So regarding the infarct vessel revascularization, these are the guidelines. In patient with STMI and ischemic symptom less than 12 hours, PCI should be performed to improve survival. In patient with STMI and cardiogenic shock or hemodynamic instability, PCI or CABG is indicated to improve survival irrespective of time delay from MI onset. And this SCC guideline also favors in favor of revascularization. Take home message, total occlusion of the left main is rare but extremely life-threatening. Optimum treatment or guideline is not clear. Prompt and aggressive treatment may save the life. Acute MI with cardiogenic shock with left main total occlusion, there is no clear-cut guideline. Thank you very much.